So, greetings, class. Um, so next week we will be finally discussing dysrhythmias. I know that you guys have said that you have not had um, anything so far since you have been, I suppose, in the nursing program where you have studied dysrhythmias or strips, EKG strips, if you will. And and so there's quite a bit of material to cover when discussing dysrhythmias. And so I would like to be as strategic as I can possibly be and make sure we get through as much as we possibly can. And so what I would like to do, um, I do have some, I think I posted a voiceover in the modules for you that I cover a certain segment of this information. But when we come to class on Wednesday, I would like to start with, I think it's slide maybe 10 or something like that. But the few slides that I want to discuss with you now, they're kind of more or less the preliminary or basically the anatomy and physiology, kind of give you a bit of background about dysrhythmias. Something that I don't think I should, you know, use at our class time for. I guess is what I'm saying. And so, and I will send you an email, of course, and I will ask you to try to listen to this before we come to class. I hope you do because when we do come to class on Wednesday, and the point at which I will start, things would make more sense to you. All right. And so, like I said, I'm trying to be more strategic here. Um, we have to do that combination of in-class discussions as well as voiceovers. And so I just want to make sure I give you everything that I can give you so that you might feel more comfortable as you look at these different rhythms. All right. So let me go ahead and share my desktop. So I don't want to take up too much time. I want to try to make this as as short as possible. That way you will possibly listen to it before class, and then we can just keep right on trucking. All right, so we are looking at care of patients with dysrhythmias. I thought it was cute to put here the electricity here, as well as the heart muscle, and this is actually a heart muscle cell, right? And so, of course, these cells make up the heart. And as you all should know, at least by now, even without having a dysrhythmia course, but the fact that you guys have had an anatomy and physiology course, the heart consists of an electrical conduction system, hence the picture I have here with the electricity. And this is what we actually defibrillate or cardiovert patients with. We deliver electricity to their heart. And then also you have a heart muscle. And one thing you must keep in mind is that in order for the heart muscle to contract, it must be stimulated by the electrical conduction system, right? Right. That's something that you all know, I'm sure. Now, um, you should also know, because we've talked about this quite a bit even before this particular discussion. The heart is an intricate pump that perfuses the entire body with that oxygenated blood and nutrients and so forth. Now, if the heart is broken, all right, as in, for example, a heart failure or cardiomyopathy, and what have you, perfusion, of course, to our organs and tissues are going to be impaired. All right. And this, of course, will result in dysfunction of those tissues and organs. One of my perfect examples that I tend to give is if you don't have adequate perfusion to your kidneys will shut down and the cells of your kidneys will die. And of course, these patients will go into renal failure. Now, cardiac dysrhythmias are abnormalities abnormal rhythms of the electrical system and can affect the heart's ability to effectively pump blood throughout the body. And some of them can be life-threatening, especially the ventricular dysrhythmias, because the left ventricle for example, pushes blood out into the systemic circulation. And this is how our tissues and organs are fed. And this is how they survive. This is how they live, right? And so now there are some main causes that can affect the electrical conduction system. And for those main items would be coronary artery disease, electrolyte imbalance, and also actually three. Actually, yeah. So impaired gas exchange can also lead to abnormal heart rhythms. Now, let me show you a quick picture here so you can get an idea about what I'm talking about. Uh-oh, could not do. All right, I want to show you a picture of a heart. So one thing I need you guys to keep in mind is that not only is the heart made up of myocytes or these cells, right, called myocytes, but the electrical conduction system, the SA node, AB node, as you can see here, the bundle of hairs, the left and right bundle branches, as well as the Purkinje fibers, that's the entire electrical conduction system. Well, these tissue are also made up of cells. And as we know, cells require, again, oxygen, nutrients, minerals, the electrolytes like calcium and sodium and potassium and so forth. Um, so our cells, even in the heart, at the conduction system, it actually requires these essential items in order to function well and carry out their job, right? And so what I want you to think about is when someone has coronary artery disease, you see, um, the heart has coronary arteries. Coronary is heart, of course, and of course, arteries. So the heart has arteries that when the left ventricle relaxes, our coronary arteries are being perfused. And of course, all of these tissues in the heart, the electrical conduction system, the heart itself, its cells are being perfused, right? And so if someone has coronary artery disease, they have basically, let's say, this plaque buildup. And so perfusion is going to be altered because the plaque buildup narrows the lumen of our arteries that supplies these different parts of the heart, the electrical conduction system, as well as the heart muscle. So then when the heart's conduction system, the heart muscle itself, is lacking in those essential nutrients and oxygen and so forth, the minerals, then they go into dysfunction and you will begin to see dysrhythmias as a result. And of course, the opposite of that is if the heart is receiving everything that it needs, then you will see a normal sinus rhythm. And we'll all learn about the different rhythms, of course, but it would be a normal rhythm. In other words, it would actually look like this. It would be a P wave, a normal looking P wave, a QRS. And look at my cursor here. And of course, the T wave. It would look like that as long as the muscles of the cells of the heart, the cells of the conduction system is adequately perfused. Now, electrolyte imbalance is also one of the causes. Remember, in order to create this electricity, even contractions of heart muscles, and think about calcium in that regard, but the different electrolytes, the potassium, the sodium, and so forth, they're going in and out of these cardiac cells. The electrical conduction, system, in order to bring about this electrical activity, right? And of course, if someone has an electrolyte imbalance, then that means that the cardiac tissue, the conduction system is not being adequately, it's not getting an adequate delivery of electrolytes, and so it can't carry out its function. And of course, abnormal rhythms are going to be seen in these patients. All right, so you got that so far. We talked about the coronary artery disease, where you're lacking in the essential nutrients, oxygen, and minerals, and so forth. And then you have the electrolyte imbalance because our cardiac tissue, be that the electrical or the myocardium, its cells depend on those electrolytes. This is another reason why I always tell you all to know your labs. When you're getting a handoff report, you want to know what those labs are because you may go in your patient's room after not getting that information, and you may see that the patient is showing these abnormal rhythms, right? And so one of the first things that they're going to do is draw a BMP to look at those electrolytes because the patient might need to have the electrolytes replaced, right, or repleted, if you will. All right. Now, and of course, impaired gas exchange, that's a pretty easy one because whatever the reason is for the impaired gas exchange, which can be due to CAD, it could be maybe someone is in some kind of a respiratory failure or an AMI, ischemia, and what have you. And so, if there is a reduction of oxygen to the conduction system, remember the arteries carries blood to our electrical conduction system as well. But if there's a lack of oxygen, then dysfunction is going to sit in. Again, think about the basic functions of our cells. It doesn't matter what cells there are. It could be uh, 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 cerebral cells. It could be cardiac cells. It could be pulmonary cells, kidney cells. It doesn't matter. If these organs and tissues are not adequately oxygenated, they're not going to function very well. So these are some of the main issues that can lead to abnormal heart rhythm. All right. Now, another thing I need you all to think about is that the electrical conduction system of the heart, think of it as a puppet master. All right. Remember, you got the puppet master and the puppet. So think about the electrical conduction system as a puppet master. All right. And the heart muscle, of course, is the puppet or that is being controlled by the puppet master. If the electrical conduction system is beating, or rather, or not beating, if the electrical part of the heart is sending erratic, chaotic impulses, electrical impulses, right? Then the heart muscle will also beat or contract erratically, right? Erratically, excuse me. Thereby, this is going to lead to poor perfusion or circulation. Think about, for example, if the electrical conduction system is just is sending impulses chaotically. Let's say, for example, ventricular fibrillation. Um, Whatever that electricity is doing, the heart is also doing. It's just fibrillating, right? And so when that happens, perfusion is going to be poor, and the patient, and in the case of ventricular fibrillation, for all intents and purposes, the patient is dead. They're clinically dead, really. All right. So whatever the electrical conduction system is doing, all right, the heart it controls what the heart muscle is doing. All right. So I want you guys to keep that in mind when you think about the electrical conduction system and its relationship to the heart itself. All right. Now, the heart's electrical conduction system is responsible, as I mentioned, for stimulating the heart's muscle to contract. All right. And of course, this causes blood to propel forward. Of course, on the right side, blood is being propelled forward to the lungs for gas exchange to take place. And of course, on the left side, the left ventricle is squeezing and pushing blood out into the systemic circulation. And it all depends upon the cardiac conduction system, that electrical conduction system. All right. So it has to be electrical first, and then muscular contraction follows, or muscular, basically we call it depolarization. All right. So it's the electrical first. For example, when you look at this, the SA node, it sends that electrical activity first, and then of course the atria will contract, or the depolarization is taking place. All right. Once that impulse reaches the AV node, there's going to be a delay. This delay of this electrical impulse that is coming from the SA node, there's going to be a delay of about 0.04 seconds. The reason there is a delay is because the left and right atria has to squeeze all of its contents into both the left and right ventricle before that impulse continues, right? It happens very quickly. And so once the contents are squeezed into the left and right ventricle, then that impulse begins to travel again, the normal conduction pathway. And then eventually left and right bundle branches and the Purkinje fibers. And then, of course, we get that ventricular contraction or ventricular depolarization. The contractions is basically depolarization, but it's all due to, again, a stimulation from the electrical conduction system. Again, electricity first, and then muscular contraction. Now, the muscular, well, see, so the electrical activity is one thing. That's what you see on a monitor, rather on the EKG monitor. You'll see this. This represents the electricity that is taking place. But when the heart squeezes or when it contracts, that is what we call mechanical activity. So we have electrical activity, which I just explained, and then we have mechanical activity. Mechanical activity is when the atria and the ventricles contract. We also refer to this as upstairs and downstairs, right? Atria are upstairs because we have some drugs that we use to try to fix upstairs problems or atrial problems, and we have drugs that fix the ventricles, or those downstairs drugs. So keep that in mind as well, especially as we look at some of the drugs. All right. So again, we have the electrical conduction system, and then we have the mechanical activity. What I wanted to tell you about the mechanical activity is that um, whenever the heart squeezes, that's the mechanical activity. It actually generates a pulse, and it also generates or helps to generate our blood pressure as well. So you have some patients with a condition called pulseless electrical activity. What that means is you can see the electrical activity on a monitor. See what I'm doing here with my cursor, but you do not have the mechanical activity. That's what we call pulseless electrical activity. So remember what I said. Um, we need the electrical conduction system to send its impulses first, and then the heart muscle will follow. They will depolarize or contract. But in certain conditions that we also went over when we looked at cold management, they're like the five T's and the five H's, right? And so those conditions can lead to the fact that the muscles will not respond to the electrical activity. So it can be acidosis, it can be hyper or hypokalemia, it could be hypovolemia, and so forth. And so, all right, so that's what I want you to understand about that. Um, and of course, as I talked about, electrolytes are vital for the proper functioning of the electrical conduction system. And the heart muscle requires that potassium and magnesium, the sodium, the calcium. And again, this is the reason why you have to make sure you get your labs from that off-going nurse, so that if anything cardiac occurs, then we know what we need to do to fix it. All right, so let me just go back. All right, so I'm going to have you guys go ahead and take a look at the objectives. You can go ahead and pause this a moment, and take a look at the objectives. This is what we want you to know. All right. I won't spend any too much time on this because you guys get this in BLS. But of course, as you all can see here, this is an automated external defibrillator with electrodes. All right, on AED. I did provide a YouTube video for you to look at if you care to. Both laypersons and healthcare providers use this device. They can be found in malls, airports, at gyms. They have them at my gym, and also commercial jets. So they have this device at a number of places. You guys already know that there's some prompting that takes place. This device is very simple to use. It tells you exactly what to do. Excuse me. Some things to remember is that you want to place the patient on a dry, firm surface. We typically use two large adhesive patch electrodes. They're placed either anteriorly and laterally. And I think for the most part, that's what you'll see on the within the package, if you will. All right. And of course, the rescuer must stop compressions, and everyone must move away from the patient before defibrillation or the shock occurs. So really basic stuff with that. So not anything to belabor. All right. Now, as far as the concepts here, we're still back to perfusion. So the priority concept here for this chapter is perfusion, right? Because if the heart rhythm is not is off, if the patient is experiencing a dysrhythmia, then perfusion is going to be altered. All right, and some of the interrelated concepts for this chapter will be fluid and electrolytes. You understand now why this would be an interrelated concept, because remember, electrolytes are constantly moving in and out of cardiac cells, right? The electrical conduction system, the cardiac muscle, and it allows it to work properly, right? And then, of course, clotting is another interrelated concept. Remember, when the puppet master or the electrical conduction system is quivering or fibrillating, so does the myocardium of the heart muscle. Blood becomes more stagnated, and when it becomes stagnated, it clots. And so these patients can develop blood clots that can move to vital areas, the brain, the heart, the lungs, and cause some really major issues. All right. All right. So this is of course, again, the electrical conduction system. The electrical conduction system, again, is initiated first, or the electricity is initiated first. And then, of course, the mechanical function or contraction of the cardiac muscle follows. And again, this is how a pulse is generated and a blood pressure is produced. So basically, the electrical system innervates rather, or affects the cardiac muscle. All right. So think about this. So you can have electrical activity without muscular contractions, but not the other way around. You'll never get heart muscles that are contracting without the electrical conduction system doing its thing. All right. So, from when the electrical conduction system is doing its thing, but the muscular system isn't, again, that's why we call it pulseless electrical activity. All right. You don't have muscular activity, which means with the pulse, without the electrical stimulation. So, um, just kind of want to throw out that distinction. Now, I told you that the electrical system has specialized myocardial cells, and cells is the key. Our cells need oxygen and nutrients and the minerals and so forth. All right. Now, these cells regulate heart rate, rhythm, and it has unique properties. All right. These cells of the heart have properties that other cells in our body does not. And so what I mean by that is, so for example, if someone was to cut out a person's heart while they're living, did you guys know that the heart will still beat? Right? Not for very long, of course, but it will still beat. But it's because of how these cells are made up, their properties, their characteristics. They're different, right? Um, and these different properties we refer to as automaticity, excitability, conductivity, and also contractility. The contractility is probably the easier one for you to understand. And I did provide I think, some really great examples of this. This is why the heart does what it does. And so I'm going to have you all take a look at that as well. All right. Now take a look at the cardiac conduction system here. You all already know that we have the SA node, which is typically referred to as the pacemaker, but it doesn't always have to remain the pacemaker. Sometimes if someone has an AMI, let me show you this. The pacemaker is here, the SA node. And so the artery that supplies this area, or the right atria, if it is occluded, let's say from an AMI, then the SA node, that pacemaker tissue, will be deprived of oxygen and nutrients and so forth, and it won't work anymore, right? Until we get that artery, get that blockage or occlusion um, fixed. All right. And then in that case, what happens is the AV node will take over. All right. And become the pacemaker. So just about at any point in this pathway, this cardiac conduction pathway can take over as the pacemaker. The only problem is the heart rate decreases as you move from the SA node being the pacemaker to the AV node bundle of hairs and so forth, as you can see here. So look at the SA node, the normal electrical impulses. So what this means is, let's say, for example, 70 electrical impulses are firing from the SA node. Those impulses will follow the normal pathway. And so while this is firing 70 impulses, then your heart rate will be 70 beats per minute, because 70 electrical impulses are also reaching your ventricles. All right. So I want you to understand that. All right. So However many impulses are being fired here, as long as everything is working normally, say if it's 100 electrical impulses that are being fired from the SA node, they are eventually reaching the ventricles. And of course, we have an atrial rate of 70, and we have a ventricular rate of 70. They're equal because the impulse is originating from the SA node. All right. Now, the SA node, again, the rate, the electrical impulses normally is 60 to 100 beats per minute. Of course, you will see that by a P wave on the ECG. All right. This is the P wave. This represents atrial contraction. This is a P wave. This is what it should look like. All right. And then, of course, you have the atrioventricular junction, and this is the AV node. We normally look at this will comprise the PR segment on the ECG. But what I want you to know here is, look at the electrical impulse here. When this is destroyed for whatever reason, let's say an AMI, and the AV node takes over, look at the heart rate now. Now it's dropped to 40 to or 60 to 40 beats, 40 to 60 beats per minute. All right. Maybe a patient can tolerate a heart rate of about 40, maybe, and maybe not. Especially when they're older, it's much more difficult for a heartbeat of 40 to help sustain a cardiac output. Because as the heart beats drop, so does your cardiac output, and so patient may not be able to withstand that. But of course, this is the AV node here. This can take over as the pacemaker of the heart, especially in the case of an AMI. All right. Um, all right. And the bundle of his. Take a look at the electrical impulses that this part of the conduction system, what it delivers, 20 to 40 beats per minute. So again, as I told you, you see how as you go down further, electrical conduction system, the heartbeat, it decreases more and more. Now we're down to 20 to 40. This is likely not going to sustain. It's not sustainable. All right. This is something that the patient is not going to be able to tolerate. All right. Now, the Purkinje fibers, even though it doesn't have it here, I believe some sources might even say that the heartbeat could be down to like the 20s. If this is the only thing you got left that is viable of the electrical conduction system. But don't hold me on that. That's just what I sort of kind of remember reading. But the biggest takeaway here is as you go down further, the heart rate gets slower and slower, and the patient may not be able to tolerate that very well. Let me do this right quick also. So you guys can see the SA node, the AV node, and this is the pathway, by the way, that the electricity is traveling. Again, SA node, AV node, the bundle of his, which is here. And then, of course, you have your right branch, this is your right branch. This is your left branch. And of course, these are your Purkinje fibers here. When this is stimulated, it causes the QRS complex that you see. All right, and that you can see QRS complex here. When the electrical impulse reaches this part of the electrical conduction system, it squeezes, but the electricity, as it travels, it is going to give you this configuration, the QRS complex. All right, and then of course you have the T wave, and that represents what we call repolarization. This is basically things are going back. It's going to reset, right, and start all over again at the SA node. All right, so that's what your T wave is. What we're most concerned about in interpreting EKGs, looking at EKGs, is the P wave, the QRS complex, and the T wave, as well as the ST segment. ST segment is more important when we're thinking about an AMI, infarction versus ischemia. And so we'll talk about all that as well. So just wanted to kind of give you a quick overview of this what this is showing here, and you can see this as well. Oh, the QT interval, we'll look at that as well. And actually, for the QT interval, you would normally get that information from an EKG. When an EKG is done, it has these different values on it. And I believe the normal value for a QT interval, it's I want to say 350 to like maybe 430 or something like that. I have to look at the numbers again. But anyhow, the EKG does this. This is not something you measure. The only thing you guys are going to be measuring is the PR interval and the QRS duration. This is the only thing you're going to be measuring. Um, and let me show you real quickly what I mean by that. When we begin to analyze these rhythms, we need to know what the PR interval is, because this is the normal sinus rhythm. We need to know what the PR interval is, and I'll show you how to measure that. And we also need to know what the QRS duration is, and I'll show you how to measure that. Those are the things that we're mostly concerned with. And the reason I want to bring that out is because you're going to see, this is a normal sinus rhythm, by the way. You have the P wave, the QRS, T. P wave, QRS, and T. All right. So a reason I wanted to bring that out is you're going to see all these different letters here, because this is what more advanced practitioners would use when they're looking at someone's cardiac health. But we're not worried about all these different parts of the electrical conduction system. And so we're going to keep it pretty simple. So don't be afraid. Let's see. Where am I? Review. All right. So this is review of the cardiac electrophysiology or the specialized myocardial cells. Remember, I told you that um, the myocardium or the cells of the heart are the most unique, right, of the entire body. No other body system, its cells are like the electrical conduction system. Impulses, all of the cells can deliver an impulse, right? For example. So, all right. So let's look at automaticity. All right. So you asked the question, what is automaticity? What does this mean as far as cardiac cells? So automaticity is like the rhythmic beating of a drum in a marching band. Just as the drummer keeps the beat without external cues, it doesn't rely on anything else. It does it on its own. Cardiac cells have the innate ability to generate electrical impulses spontaneously and rhythmically. Right? See, the drum, he's just doing his thing on the drum, just beating, and nothing is telling him what to or her what to do. They're just doing it. They're just doing it. They're just beating. Any of your cells have the ability to do that. Has the ability to generate an electrical impulse. In other words, what I mean by that is, uh what I mean by that is, remember I told you that the electrical impulse normally starts here at the SA node. That's what it normally does. But if the SA node is adversely impacted for whatever reason, remember all of these are cells, right? This is like a slice view of the heart, but all of these are cells. Just imagine all of these are cells. And when we think about automaticity, any of these cells can generate an electrical impulse. One reason this is important is whenever you think about atrial fibrillation, the reason why you have those fibrillatory waves in atrial fibrillation, um, while I'm at it, let me just show you that real quickly. Um, the reason you have, all right, you see these fibrillatory waves? The reason you have these fibrillatory waves, the reason they look like this, rather, as opposed to, all right, I want you to keep this in mind too, so I don't have to come back to it. These are sawtooth patterns. This is what we call atrial fibrillation. They look like sawtooths, right, in between the QRS complexes. But the reason why you have this, the fibrillatory waves, right, no discernible P wave at all, versus these sawtooth patterns is because of this. Go back. All right. So in atrial fibrillation, remember I told you any of these cells can generate an impulse? So what's happening in atrial fibrillation is the impulses are firing all over the place. Look at my cursor. It's just coming from all over the place. Because of that, you have these fibrillatory waves in atrial fibrillation, right? They're coming from everywhere. It's not coming from the SA node at all, where it's supposed to originate. It's just coming from all these different cells. So it looks erratic, chaotic, right? Now with atrial flutter, it's still not coming from the SA node, but it is coming from one area, just firing off impulses. And that's why you see the sawtooth pattern, and it looks more regular. The interval looks more regular. When I say the interval, I mean, I mean this. You see the interval from here to here, it looks regular. When you look at a atrial flutter, right? When you look at atrial flutter, it looks more regular. Atrial fibrillation is irregular. Atrial flutter is more regular. It can be irregular, but most of the time it is regular, and that's only because it's all firing from the same spot, right, in the atria, other than the SA node. All right. Now, one thing I want to also make sure you guys know is that um, our initial discussion will be about those rhythms that originate from the atria or upstairs, right? And then as we get further into this discussion, we'll talk about those downstairs or ventricular issues. So the first part of our discussion is more atria, and then afterwards our ventricular issues, right? And then of course you'll see as you progress through this presentation, you'll see when I begin to talk about the ventricular issues like ventricular tachycardia, ventricular fibrillation. All right. So right now our discussion is more about what's going on in the atria region of the heart. All right. So that's automaticity, right? Now, so an example of excitability. Excitability is the other concept here. So it says the ability of non-pacemaker heart cells to respond to an electrical impulse that begins in pacemaker cells. All right. So remember, this is where the impulse usually originates, and all the other cells will respond. All right. They will be stimulated as well. It's kind of like moving in a certain direction, right? The best way to think about this, imagine a relay race where each runner passes the baton to the next in line. So each cell is in line as it moves a certain direction. So in the heart, the pacemaker cells act as the initial runner, right, in the race, carrying the electrical impulse like a baton and passing it along to the non-pacemaker cells or the next person in line, right? Now, excitability is akin to the readiness of the waiting runners. So somebody is waiting to get that baton, right? And they're going to spring into action as soon as they receive the baton, and then they'll move on until they get to the next individual or the next cell. So when stimulated by electrical impulses from pacemaker cells, the non-pacemaker heart cells become excited, right, and ready to initiate their own electrical activity. And this ability allows the heart's electrical signals to what we call propagate efficiency throughout the myocardium. It allows the myocardium to contract, in other words. It ensures a coordinated contraction and proper pumping function of the heart. And so that's why excitability is so important. How this it's basically how the cells respond. Now, the last, or not the last one, but an example of conductivity. Imagine a synchronized dance performance where dancers hold hands and move in a kind of unison. In the heart, conductivity is like the seamless coordination between dancers, allowing the electrical impulses to flow smoothly from one cell to the next. Picture a wave traveling through the dancers as they pass the energy along. So similarly, in the heart, conductivity enables the transmission of electrical signals from one cardiac cell to another. And this ensures that the heartbeat is synchronized and it is rhythmic. Just as each dancer in the performance plays a crucial role in maintaining the fluidity of the movement, each cardiac cell's ability to conduct electrical impulses contributes to the coordinated contraction of the heart muscle, ensuring that effective blood circulation is happening throughout the body. And of course, the last one is pretty easy to understand. It talks about the ability of the atria and ventricular muscle cells to shorten fiber length in response to an electrical stimulation. And this causes sufficient pressure to push blood forward through the heart, which is that mechanical activity that I talked about. All right. And so it's just the atria and the ventricles, they are contracting or they are squeezing. Right. I did provide these examples here for you, and so I want you to just take a look at them, kind of study it. Tell me what you think about it. All right. Um, all right. So as you can see here, no other cells in the body is able to do what the heart cells are able to do. So that's what makes them so unique. All right. And here, I won't stay on this one too long. Basically, this is how we place leads on our patients. All right. They usually have people in the hospitals. Now, so in the ED, the ER nurses will probably apply these leads and run the EKG. But on the regular floor, they might send an EKG tech or maybe the respiratory therapist. They are tasked with doing EKGs. And so, but it's still good to know what they're actually doing. And basically, as you look at these different leads, B1 through B6, I think, yeah, B6, all that's basically happening is that these leads and how they are placed, they are looking at the heart at different angles. In other words, you're not just looking at the heart in a frontal view. You're looking at a lateral view, an inferior view, a posterior view. You're looking at all these different angles of the heart, right? And if you look at an EKG, you'll see that you have this V1, V2, V3, and so forth, and that's because it can show you where there is a problem. So, for example, V1, and this is not exactly what it is, but just to give you an idea, because I have to always look at it. But V1 might look at, let's say, the arteries that supplies the left ventricle. And if that ventricle, excuse me, if that artery is occluded as in an AMI, it is going to show in elevation in that particular lead. I did bring up some information just to kind of show you. Actually, let me see if I can bring that up quickly. Oh, here it is. All right. So take a look at this. So you see here where it says the lateral leads. This is more lateral. It's in lead 1 and ABL. You have the anterior septal leads, and that's located V1 to V4. And look at that. That's actually somewhere around the left ventricle. Also the lateral leads V5 to V6. So it's looking at different angles. And I'm just giving you an idea. You don't have to really know this, but I'm just giving you an idea that when you are looking at these EKGs, this is what this is what this device is showing us. It's showing us where the lesion can be, right? All right. I want to show you that. All right. And I do have an example of an EKG on this slide as well. Now, you guys, when you are in the at the bedside and you have to place the leads on the patients, there is like a mnemonic that we use to determine what goes where. So on the right side, it's usually, even though this is colored red, but the white lead goes here, the black lead goes here. The brown one, I think it's chocolate, is close to the heart or something. Some of you all probably know it better than I do, especially if you're a tech and you're given the job to place the EKG leads. But it's usually let's see, so cloud, right? So this would be like a cloud because the clouds are white, and it would be over a green lead. So like grass, cloud over grass, right? So a white lead over the green lead, cloud over grass or green grass. And over here, it's black as in smoke, and this would be red. This would be actually red. So smoke over fire, right? So a black lead, which represents smoke, over a red lead, which is the fire. Now, this is an extra one that we usually don't have to apply, but again, it's just looking at the heart from a different angle if you do the 6 leads. That just gives you an idea of how we place leads. We can go into that a little later if you want to, but it's something you'll learn at the bedside. And you can also, when you're at the bedside, just make sure you go into your patient's rooms and look at how the leads are placed. One thing you want to make sure you do is make sure hair is removed and skin is cleansed before you apply the leads. So you may have to use a razor to shave those areas, especially on males. We also, at times, we would take like a 4x4 and we will roughen up the skin, and then we'll place the leads on top of it, right? Because it helps it to stick a whole lot better. All right. Um, Sometimes they change out these leads. I want to say every shift, maybe every 12 hours or whatnot. Because when the patient is sweating, and especially if you place it on top of hair, they don't stick very well. And it looks like a bunch of artifact. So when you're looking at your EKG on a monitor, it looks all fuzzy, right? Because these leads do not have good contact to the skin. All right. So make sure you're watching these leads. Make sure you applying them correctly, and also make sure you're checking your patient first, as opposed to primarily using the EKG system, because sometimes if a patient is shivering, it may look like the patient is in ventricular fibrillation, but the patient is sitting up there in bed, laughing and joking and watching TV. So the patient can be in ventricular fibrillation if that's the case. So you always want to make sure you check the monitor first. I'm sorry, check your patient first, and then, of course, your monitor. Let's see if there's anything else. All right, I think that's about it. So I did keep it under an hour. And that's so when we begin again, we will be starting at slide 11. This is kind of more or less the fun part, because now you begin to learn how to read EKGs, or interpret them. Let me see. I thought I had something else here that I wanted you to look at while I have this still up, and I'll be able to bring it up again. It yeah. So check this out. Look at the different arteries that supplies various parts of the body, of the heart muscle rather. So you have your right coronary artery here, right? And this is around the atria, especially where the SA node is located. So if the right coronary artery is occluded, it is possible that, of course, these patients will experience a dysrhythmia because that cardiac tissue is not being properly supplied. I don't know what this one is. Um, I would like for you guys to take a look at starting with page 628, cardiac catheterization. I want you to read that. The patient prep. See, read all that. It's not much actually. The procedure itself, and then of course the follow-up care. I really would love for you all to read that. It's not a lot of reading, but it can appear on test. So please read that. And it starts with 628. All right, folks, I think that's about it. I hope again you take a look at this information, listen to this information before our class starting on Wednesday, and that way we'll be certainly further along, and we will cover much more information. So this stuff I just covered is more the preliminary background, anatomy and physiology type of stuff, just to kind of give you that refresher, that you probably forgot about. So anyway, thank you all, and I will see you soon.